Good morning. Welcome to our webinar this morning. My name is Graham Abbott. I'm the Suicide Prevention Lead for Suffolk. Our topic today is domestic abuse. So I just want to start with a health warning. Both domestic abuse and suicide prevention, obviously, really sensitive topics. So it's really important that we look after ourselves. So I'd encourage you to step away if you need to reach out to colleagues or friends, or to seek help if you need to. Some Suffolk context: we have around 70 deaths a year in Suffolk that are recorded by the coroner as a cause of death is suicide, and this is in line with the national average, but obviously every one death is a death too many. And so often, so many deaths are not mental health crisis, but actually a response to life events and circumstances. Making suicide prevention everyone's business is important because it's the interactions that you and I have as we go about our work lives and our personal lives that will make all the difference. This webinar is part of a series that picks up various themes. So we've already covered relationship breakup, poverty, substance misuse, autism, and then this month is domestic abuse. Then next month in June, we are looking at young people and suicide. Today, our speakers are Tim Woodhouse from Kent County Council, Melanie Yolland from Suffolk County Council, and also Catherine from Restore Women's Aid. Before I hand over to our speakers, just some Suffolk context. So in Suffolk, we have a system that looks at real-time data of suspected suicides, and this shows that 17% have a theme of domestic abuse, and that's normally triggered. It could be that in our record, in our data, we're aware that the police have attended for domestic incidents, and that's the level of that data. 21% have a theme of relationship issues. That doesn't mean there is domestic abuse, but it just says there's relationship issues, and often that's a relationship breakup. And then if you add both of those together, that's and or, that's 34, just over a third have domestic abuse and or relationship issues. And before I hand over to Tim, I just want to acknowledge it's a really complex issue because there's victims, there's perpetrators, there's often co-victim and perpetrator. And also, I think it's worth highlighting that the reason why suicide has such a and domestic abuse have a link is because of the issues around inner pain and turmoil of being entrapped by the situation and perhaps defeat and humiliation, which relates to the integrated motivational and volitional model of suicide behaviour. So without any more to do, I'm going to hand over to Tim Woodhouse from Kent. Thank you, Tim. I'll stop sharing.
Thanks, Graham. That's really powerful instruction, and actually I'm really pleased to hear that you count, or you have, domestic abuse as a theme within your real-time suicide surveillance. Not many other areas do that, so that's a great perspective to be working from already. And I'll come on to a little bit about what we found within the Kent Medway real-time surveillance system as well. So as you can see on the screen, and as you've heard from Graham, I work in Kent County Council's public health team as the suicide prevention lead. I've been there since 2011 and have done a number of pieces of work around the risk of suicide amongst people impacted by domestic abuse. And over the next kind of 15 or 20 minutes, that's what I'm going to obviously be talking to you about. And just to repeat kind of Graham's health warning, please look after yourself. I'm not going to be offended, and I won't even know if you disappear and look after yourself and go and grab a cup of tea. It's raining here in Kent, so I imagine it's probably similar in Suffolk, so maybe not a time to go out in the garden, but just look after yourself. I do have some quotes that are being read out, so they are quite powerful. So just be aware, from victims of DA who have tried to take their own lives. Okay, so I said I've done a couple of pieces of work on this. I've completed a Churchill Fellowship, and if you don't know what a Churchill Fellowship is, excuse me, I'll tell you a little bit more about that later on. I've also completed an academic fellowship at the University of Kent, and I'm hoping to start a PhD in September on this issue as well. So these are the stats that the Kent and Medway equivalents of what Graham's already kind of talked about from a Suffolk point of view. 33%, so much a greater proportion actually than Graham mentioned in terms of our suspected suicides in Kent and Medway. Sadly, we do get a higher number of deaths per year than Suffolk. So you can see out of the last 6 years, 291 deaths have been impacted by domestic abuse out of the 890 suspected suicides that we've seen. That is a huge figure, both in terms of proportion and actual numbers. But we know, and I've put very likely on the screen. It's not very likely. It's definitely going to be an underestimate, given that we know domestic abuse is massively underreported, both to the police, or especially to the police, but also to friends, family, and support services. So there'll be many people who are dying, having been impacted by DA, that are not known and not included in these figures. So Graham's already highlighted this as well. It is complex. It is nuanced. When we first started collecting the real-time suicide surveillance data, we literally had one column, which was a tick box: domestic abuse, yes or no. And it was being ticked so often that we realized that we had to do a lot more fields and better data collection. So we do ask whether that's amongst victims, amongst perpetrators, and there's this third group that I'm really concerned about, that are people who are known as both victims and perpetrators. There's so much we don't know about this issue, but I think this group in particular is one of those that we need to do a lot more work on. You can see the high proportion of males within that group in Kent Medway. My gut feeling is that these are men who are making counter allegations, malicious counter allegations against their partners, but we can't really prove that at the moment. And I think the females in this group are probably, and I don't like the term primarily a victim, I think they are absolutely victims who are either subject to malicious counter allegations, or the violent resistor typology, who use defensive violence to protect themselves, but then are labelled as a perpetrator by the police. I'm really worried about this group. I'm really worried about all the groups, but you can see in terms of the highest individual numbers are amongst people who are known as both victims and perpetrators, and where the abuse is both recent and historical, and it's been going on for a long time. I don't like the word historical, really. If I could change that and go back in time, I would do, because just because it's happened in the past doesn't mean that it's not having an impact on the future. Historical kind of makes it sound as though it's kind of finished and tucked away neatly. In many cases, it's not, and the long-term impact of that, the trauma, is really damaging to the victims. So how do we compare with other areas? So I'm going to add Suffolk to this slide now that I know your figures, but we know from Australia, who've undertaken a much larger sample, that they found that 25% of their suicides have been amongst people impacted by domestic abuse. So 25% is not quite the 33% that we see in Kent Medway, but it's there or thereabouts, and it shows that it's a huge proportion. And although I'm from a public health background, I should be careful what I say about the level of detail that we need about stats. I'm not very worried about whether it's 25.3, whether it's 33.2, whether it's 28.6. It's a massive number that we're not really taking enough action to reduce, I think, as a country. Some people might also be aware of this National Police Chiefs Council report. They published about 2 years worth of data now, and found that the person most likely to kill a victim of domestic abuse is themselves. So there are more victims of DA dying by suicide than there are being murdered by their partner. And so, yeah, this next slide is just a repeat of that phraseology. The person most likely to kill a victim of DA is themselves. And I think that has huge implications, not just for the suicide prevention sector, but also obviously from the domestic abuse sector. There is, I don't know, 95%, 98% of the efforts from the domestic abuse sector goes into keeping the victim safe from harm from the perpetrator. And of course, I understand that. And of course, I think we need to continue to do that. In fact, we need to do it better. We need to invest more. We need to keep doing that. But in addition, we also need to start taking measures including about how to keep them safe from suicide. So we've undertaken some interviews with people in Kent and Medway who have been victims of DA and have attempted suicide, trying to understand a little bit more about what their motivations for trying to die were. And this is what we found. So some victims feel that they are about to be murdered by their perpetrator.
I knew that he was going to kill me, so it wasn't a matter of choosing to die, just who was going to do it.
And that's obviously a horrific position to be in when you are so convinced that you are going to be murdered by your perpetrator that actually it's a better outcome that you end your own life, because at least you have some sort of control over the manner of your death. But that's not true of everyone.
I thought I was worthless, like I didn't deserve to be alive, and that everything they said was true. I was horrible, and that the only way out was for me to die.
So this woman told us that she just believed everything that he had told her about her friends hating her family hating her, that she was scum, that she didn't deserve to be alive, that the world would be a better place without her. She told us how her perpetrator would kind of write out a suicide note on her for her, give her the methods of suicide, and just say, right, go on, I've done everything, I've done all the hard work, you just need to do this now. Which again, obviously horrific.
You go into survival mode. You're hyper-vigilant. It's exhausting and tiring. I was sick of fighting. I was sick of surviving. I knew when I woke up that day I would attempt suicide.
So this third cohort, they're not convinced they're going to be murdered. They're not believing the lies that their perpetrator are telling them, but they just cannot see another way out. They want the abuse to stop. They want the pain to stop, but they just cannot find another way out. So they may have gone to services and not had the great response. They may have gone to the police, but not had a good response. They may never have gone to the services for fear of not being believed. But again, there was a fourth cohort as well.
I felt broken. I felt so many emotions: shame, hurt, fear, grief. I felt like damaged goods. I couldn't sleep at night. I was having flashbacks, and he was on Tinder finding the next victim.
So this kind of reinforces the point that actually the pain and the trauma doesn't stop when the relationship ends or when the perpetrator moves on. The perpetrator might be in jail, or in this case moved on to a different relationship, or dead themselves, but actually that long-term impact of the trauma doesn't go away. So this woman told us that her suicide attempt came many months after the perpetrator had moved on, but she was sat in a new bedsit and she couldn't work out what colour to paint the walls, and that was when the trauma kind of caught up with her, and so all of her friends and family were saying, "Oh, you must be in such a much better place now. You must be so relieved to be able to move on." But she was sat on the floor and couldn't even work out what colour to paint the walls, because her life had been so controlled that she was so kind of paralysed by the trauma, and that's when she attempted to take her own life. So I kind of put those kind of 4 clips in, partly just to show the nuances and the different angles that people come to the decision to take their own lives from, but also as public health professionals, and many of you will be domestic abuse professionals on this call. If we're trying to intervene, we need to know, like intervening in the 4th example, for instance, is going to look very different to intervening in the 1st example, and the same for the 2nd and the same for the 3rd. So when I start talking about recommendations later on in the presentation, just be aware that it's not a one-size-fits-all solution. Different people are going to need different interventions. So, okay, what is the Churchill Fellowship? Just phenomenal opportunity. So they're a charity who fund UK citizens to go anywhere in the world and research anything you want to research. The only stipulation is that you come back and try and do some good with what you found out. So if that sounds something that you're interested in, please go for it. Check out the website. obviously me speaking to you today is me trying to do something good with what I have learned from my experiences in well, around the world. It's just phenomenal. But I want to share some words from people I spoke to on my travels. So this is Tia's story.
He was smiling, like smiling the most evil smile I've ever seen in my life. And he said, "You thought you could get away from me, didn't you? You thought you could leave me." And it was at that moment I knew I was in real trouble. I screamed, I protested, I told doctors, I told social workers, I told psychiatrists, I told friends, I told everybody. But nobody believed me. It was already too late at that point. He made them believe I was a crazy person, right? All I wanted was to be believed about the abuse and what he was doing to me. If literally one human being had looked me in the eyes and said, "I believe you," this would have been a completely different story. But nobody did. They laughed in my face, they bullied me, and I tried to kill myself.
So Tia is a really good reminder to all of our services that when somebody tells you and takes the time and the emotional energy to tell you what is going on, please believe them, because they're probably 99.9 times out of 100 telling the truth. And if you don't believe them and you don't support them, then it could have absolutely devastating consequences. I should highlight that Tia's doing much better now. Their suicide attempt was about 5 years ago, and they are in a much better place. I also wanted to highlight Essence's story.
Take Essence, for example. She was being choked and pinned against the wall by her former partner, who had abused her for months. After the incident, she called the police, but because he had a visible scratch on his chest from where she had tried to defend herself, she was the one arrested. I asked him to please leave me alone. It was the only time I stood up for myself. She was convicted and court-ordered to attend and pay for a 30-week anti-violence intervention. Her attendance was mandatory and clashed with her work, so she lost her job. Essence's single act of self-defence and violence eclipsed her entire history of victimisation and led to an entirely disproportionate systems response. This was exceptionally damaging to her physical, financial and emotional well-being.
So Essence lives in the States, and I've had people, when I've given this presentation before, to say, "Oh, well, that wouldn't happen over here because we don't have those 30-week anti-violence interventions. It wouldn't happen in the same way." And to an extent, that's right. It wouldn't happen in exactly the same way. But I know, and I've sat on DHRs where women in very similar situations like this have been labelled as perpetrators by the police, have been arrested, and there are a whole set of system responses to that from social services, from the police, from their employers, that are just as damaging, even if the precise nature is slightly different. But the last story I want to share is Julie's, and Julie brings a completely different perspective to this issue.
My ex-partner was arrested for stalking me and then killed himself. He left a suicide note blaming me for his death. We have a 6-year-old daughter together. Off the back of his smear campaign, his friends and family continued his abuse. They tried to change the locks of my house. Their solicitors threatened civil and criminal remedies against me. It's honestly a shit show. His suicide is an act of misogyny and coercive control. There's no part of our lives that's not been impacted by his decision. Our hearts, our bodies, our mental health, my career, our friendships, and our capacity to exist fully in the world. His cruelty is overwhelming. On bad days, I wrestle with the shame that maybe I am to blame for his death. By leaving, by protecting my daughter, by calling the police, his friends and family are quick to give me that blame. But the fact that you choose to not put up with somebody else abusing you, that doesn't make you responsible for whatever they choose to do next.
So I've had people in the past ask me why we should care about perpetrator suicides. And one, just from a suicide prevention perspective, it's a humanitarian thing. Like, I don't want anyone to die. But actually, the second reason is that if we are truly victim focused, and if we really believe that, then absolutely we should be keeping trying to keep these perpetrators alive, because their deaths can cause huge damage, lifelong damage to Julie and her daughter. You can see some of the pain and some of the trauma they're already going through, and that will never leave them. Julie's daughter will grow up knowing that her father killed himself and blamed her mum for that. That's a lifelong trauma that is not going to escape. And Julie is convinced, as am I, that actually it's often the perpetrator's suicide is often the ultimate act of coercive control, and the perpetrators know exactly what they're doing when they take their own life, and that is to inflict maximum damage and maximum pain on the victim. Okay, so in terms of some of the actions that I think we can take, my Churchill Fellowship report is called 66 Ways to Reduce DA-Related Suicides. I've put the link in on the slides. I'll put it in the chat once I've finished. You can go and read all 66. I haven't got time to read all 66 out to you, but I will just go through a few of them. They are grouped in 10 different areas, and you can see them on screen. Again, I won't read the 10 different groups out there, but it's supporting young people, it's supporting female victims, supporting male victims, looking at this group of people who are both known as victims and perpetrators, and you can have probably read the rest of the groups already now. My number one recommendation is that this is a national emergency. This is a national scandal, and actually it needs to be treated as such. We need a national task force to come together from both the DA world and the suicide prevention world, with policymakers, researchers, people with lived experience, academics, everyone coming together to really address kind of all aspects of this. But in terms of some of the things that I would like to kind of put forward to that task group to consider as a starting point, well, I think the first one is very simple. We just need to get better at asking victims of domestic abuse, are they thinking about suicide, and have they ever made a suicide attempt in their lives? So for those of you who are from a suicide prevention background, you'll know that this is a really important question that doesn't often get asked. And some people are a bit nervous about talking about suicide. They think they might put that thought into somebody's head. There's no evidence that that is true. And I think without knowing whether somebody's thinking about suicide, you as a professional that's trying to safety plan around that individual cannot produce an effective safety plan. Because if you don't know that they're thinking about suicide, how are you going to put interventions in place to keep them safe? So I recommend that every domestic abuse victim is asked regularly about whether they're thinking about suicide, and every domestic abuse safety plan that is put together, yes, it continues to focus on the risk of harm from the perpetrator, but now it also should include kind of sections that ask the professionals to think about how are we going to keep this person safe from suicide as well. We know this is where most lives are lost. We know most victims are dying by suicide rather than being murdered. So can we please ensure that safety plans reflect that, and on every single time are thinking about keeping people safe from suicide? You've probably read a lot of the others on screen already, but just to pick out a few, we're trying in Kent and Medway to get better mental health support for domestic abuse victims. It's really difficult. I know that there are so many pressures on the mental health system, but we're trying to be creative. We're trying to think of ways. Can we use peer mental health supporters? Can we kind of employ mental health professionals within domestic abuse charities, or can we kind of fast track routes into different mental health pathways? In terms of kind of extensive domestic abuse training, absolutely, for all social workers, for all mental health clinicians, and vice versa. So mental health suicide prevention, domestic abuse professionals need to get the suicide prevention training as well. So the training requirement goes both ways. There are other bits of things that probably, well, certainly less relevant to me. I don't know whether you've got any police or reps or probation staff on here, or CPS staff, but absolutely, I think the police should be considering charging perpetrators with manslaughter where victims of DA take their own lives. There have been a couple of court cases where that's been attempted, not necessarily got the right or the outcome that I would have liked to have seen, but I think the police are starting to consider that more. again, don't know whether you've got a suicide bereavement service in Suffolk. We do in Kent. We've had many conversations with them about how to support families and individuals where there's been a DA-related suicide. It is different. I mean, suicide bereavement is different and nuanced enough already, but when you add a layer of domestic abuse in, it becomes even more tricky, even more nuanced. And I think there's specialist training that needs to go on for the bereavement support services. Sounds like you're already doing this already. You're already giving it a real high priority and within your suicide prevention work in Suffolk, and that's brilliant to hear. And then finally, it shouldn't just be reliant on Kent or Suffolk to do our own kind of measurement on this. We do need a kind of a national measurement tool, I think, so we really understand the true picture, because I think it's much bigger than we anticipate. And then very finally, and hopefully just to head off some of the questions, and to show you that I'm genuine that we don't have all the answers. There needs to be a huge amount more research done on this. There's so much that we don't know, and again, won't pick out all the groups I've highlighted on the screen, but there's just so much research that needs to be done. I highlighted that I'm trying to get funding to do a PhD in September. I mean, that's just one PhD. I think there's at least 350 waiting to be written. You could do PhDs on any one of these individual topics on screen, and we still wouldn't have all the answers. Okay, right, I'll leave it there, Graham, and happy to kind of hand back to you.
Thank you, Tim. Yeah, just to there is a Q&A function within the webinar. So if you wanted to post any questions, we can do our best to answer them, or to ask Tim. Just to mention, in terms of Suffolk, we began a piece of work that we're, I guess, partway through in terms of working with our domestic abuse agencies to raise a profile, and I think one they asked from them was, actually, when we're thinking about safety, when they're thinking about safety planning, actually we also have the skills to actually look at safety planning within the broader context of suicide prevention as well. So that's an ongoing piece of work, and also there's a recent guidance in terms of safety planning from the NHS, which we're looking to sort of work through. The link you shared, Tim, we will put that in an email that go out to everyone who's attended. So that they can download that, and also to say that we will share your slide and the other slides afterwards. And yeah, we also have a Bereaved by Suicide service, which is currently victim support, but actually that's going to move to North East Essex Mind and Suffolk Mind in the near future, just to make people aware of that. Okay, so I'm going to move on now to hand over to Melanie Yolland, who's a colleague of mine who works in the domestic abuse part of public health and communities.
Thanks, Graham. Morning, everyone. I'm Melanie Yolland, as Graham said, and I work in public health and communities at Suffolk County Council as the project lead for Violence Against Women and Girls, or VAWG as it's known, Domestic Homicide Reviews, or DHRs, and Domestic Abuse Related Deaths, or DHRs, and that's what DHRs, sorry, DARDAs they are. And that's what DHRs will be renamed to, following calls to the Home Office to better recognise deaths from domestic abuse related suicide. So this will become official once the Home Office have published their updated statutory guidance, which is a bit out of date at the moment. It's 2016. My role within the team is to coordinate and oversee the DARDAs and DHRs across Suffolk. So I'm just going to reiterate the health warning, really. Domestic abuse and suicide is a sensitive subject. Please look after yourself, and if you need to take time out or turn off your camera during my presentation, please do so. I'm going to give you a brief overview of DHRs and DARDAs, which Tim has already referenced DHRs. I'll also talk about the Suffolk picture, and I'll focus on suicide-related deaths and how Suffolk is disseminating the learning from DHRs and DARDAs. So DHRs and DARDAs are a statutory responsibility of community safety partnerships, or CSPs as they're known, to which we've got 3 of those in Suffolk. They were established on a statutory basis under the Domestic Violence, Crime and Victims Act, and a domestic homicide review means a review of the circumstances in which the death of a person aged 16 or over has or appears to have resulted from violence, abuse or neglect by A person to whom he or she was related, or with whom he or she has been in an intimate personal relationship, or B, a member of the same household as his or herself, held with a view to identifying lessons to be learnt from this death. So when this definition has been met, a DHR or DARDA should be undertaken. They're not inquiries into how the victim has died or who's culpable. That's a matter for coroners and criminal courts, and they're not about apportioning blame. The purpose of a DHR or DARDA is to establish what lessons are to be learned from the domestic homicide regarding the way in which local professionals, organisations work individually and together to safeguard victims. It's also about identifying lessons to be learned with and between agencies, applying these changes to inform local and national policies, and better prevent domestic abuse and homicide and service responses. Also to have a better understanding of the nature of domestic abuse and also highlight good practice. So CSPs follow the Home Office multi-agency statutory guidance for the conduct of domestic homicide reviews, which has currently been updated and will include that name change to DARDAs to better recognise deaths from domestic abuse related suicides. So for the purpose of the webinar, I'm just going to keep interchanging DHRs, DARDAs. They are, it doesn't exactly roll off the tongue that easily. So where a victim took their own life and the circumstances give rise to concern, so for example, if there was coercive controlling behaviour in the relationship, a review should be undertaken even if a suspect is not charged with an offence or they tried and acquitted. As I said, reviews are not about who is culpable. And what we do with all DHRs and DARDAs, and that's national statutory guidance, pseudonyms are used rather than actual names, and that's to protect the identities of the victims, the family and others involved in the case. And this is really important because the reviews often delve into sensitive details, and the use of pseudonyms helps maintain confidentiality and prevent potential harm to those involved. So if any professionals are familiar with safeguarding adult reviews, DHRs are similar, but they take a holistic approach as they focus the review primarily on the victim and the alleged perpetrator. However, they could include other family members such as children. They also take quite a lot longer to complete, on average 2 to 3 years, and they can be really complex. And we have to allow for criminal proceedings to have taken place before we can consider engaging family members and friends in the DHR. And we engage family and friends, and again, it's part of the statutory guidance, because really it's a way of ensuring that the victim's voice is heard. Obviously they're not there to say what happened, but quite often family and friends will know what was going on, and they can also help identify what lessons need to be learnt, which will help with our changes in domestic abuse and procedures and etc. and service use providers. So Suffolk County Council Community Safety and the chair of the Community Safety Partnership are notified of the death by Suffolk Constabulary. What happens then is we pull together a multi-agency advisory panel. This is arranged with key statutory partners who sit on domestic homicide reviews. So the whole point of that is to review any involvement with the victim, and not always have agencies had involvement with the victim, but there may have been 1 or 2 incidents reported to police. We also look at the alleged perpetrator and any children, and then we determine whether it's met the criteria for a domestic homicide review. If so, as part of the statutory process, I notify the Home Office that the CSP would be undertaking a review, and then we commission an independent chair and author to undertake this review. And we've got a list of approved chairs and authors for Suffolk, which we've established over a number of years. So then panel meetings are held. They could sort of range from 3 to 5 panel meetings over the course of time. They include the statutory partners, but we also have representatives from domestic abuse services, local services, and in some cases we have also commissioned some specialist support service as well. So the panel reviews agency information and involvement to develop an overview and an action plan with recommendations. And then we also have a timescale for implementation of those recommendations. The report and the action plan has to be submitted to the Home Office, who review it, and they'll sign it off. And in the meantime, the Community Safety Partnership has the responsibility for overseeing the action plan and making sure those recommendations are implemented. So that just gives you a quick overview of what DARDAs and DHRs are, and I'll now give you the Suffolk picture about the situation, and I'll explain how we're disseminating the learning. So to give you an overview of DHRs and DARDAs in Suffolk, since they became a statutory responsibility of Community Safety Partnerships, we've had 6 that have been completed and signed off by the Home Office. We've currently got 11 in Suffolk that are underway, and all of them are at different stages. Some are just starting, some are about to be submitted to the Home Office, some are sitting with the Home Office waiting for their review and feedback. Of all the DHRs and DARDAs that we've had to date, there have been 3 perpetrators who have died by suicide. This was after they killed their partner. All 3 of those were male. Predominantly, most of the DHRs in Suffolk were intimate personal relationships, whereby the victim was killed by their partner, whom they were still in a relationship with, and although they were living in the same household, the victim had been planning on leaving the relationship. In the majority of these DHRs, where the victim has been killed, there's been subsequent criminal proceedings, and the perpetrator found guilty of murder and has subsequently received a prison sentence. However, for 3 of these intimate personal relationship DHRs, there were no criminal proceedings, as the perpetrator took their own life after killing their partner, and they were the 3 I was speaking about, and they were actually straight away after. So at the time of the death, they killed their partner and then subsequently took their own life. But recently in Suffolk, we've seen a change, and we've been notified of 2 domestic homicides where the victims have died by suicide. Both of these victims were female and had left their relationships. So in comparison with Kent, we are fortunately quite a lot lower in numbers at the moment, and that's not to underestimate the fact that we don't think that we're going to start to receive more suicide related deaths, sadly. These reviews are quite early on, so what we know so far in both these cases is the former partner continued the abuse by way of coercive controlling behaviour, by stalking and harassment, and also malicious communication. In the DARDAs where the victim of abuse died by suicide, there were no suicide notes, and unlike the other DHRs I referenced earlier, where the perpetrator had been found guilty of committing an offence by killing the victim, it can be really difficult for police to gather evidence that prove that the ongoing abuse and actions have led to the victim taking their own life. Therefore, it is possible that no charges may be brought or face criminal proceedings, which can be really difficult for bereaved families who are trying to come to terms with losing their loved ones. So these DHRs are currently underway, and the recommendations and learning from these reviews is yet to be determined. So once they're complete, the learning will be disseminated by way of as a way of disseminating to learning professionals. We now ask the independent chair and authors that we appoint for the DHRs to produce learning briefing documents that can be used as frontline professionals as case studies and training for new staff or for ongoing training. So I'm going to now just give you an example of one of the learning briefing documents that's been developed by one of our DHR chairs and authors. As I've said before, pseudonyms are used. These aren't actual names. We use those in the DHR or the DARDAs, but also for the briefing documents. So, as I said, these learning briefing documents are developed to disseminate learning, particularly for frontline professionals working in health, GP surgeries, hospitals, NSFT, and each one of these learning briefings will be different depending on the outcome of that DHR or the DARDA. And also the learning could be for other frontline professionals as well. So they could be used by police, social care, substance misuse providers, other DA services, etc., etc. This one is for frontline professionals predominantly working in the health sector and references retirement depression, which is something that was identified in this DHR. In addition, we also asked the independent chairs and authors to produce a learning briefing video, Again, that's for frontline professionals, and that's again to use as a case study and help to disseminate learning. And that's really important from DHRs and DARDAs, that we don't just do these, we implement the recommendations as a tick box. We make sure that learning is disseminated further, because at the end of the day, what we're trying to do is prevent DHRs and DARDAs in the future. And as I said, again, pseudonyms are used in these videos, not actual names. So what we're intended to do, we're intended to build a library on of these learning briefing documents and videos, which we're hoping to host on the Suffolk Safeguarding Partnership website at some point. So watch this space. And also, in addition, we're currently rolling out a programme of domestic abuse training sessions. So if anyone's interested, sorry, Graham, I'm going to ask people to contact you in the first instance, if that's okay, and then I can follow those up and come back to people directly. And then this is the second learning briefing document produced by the independent chair for the same DHR. This talks more about suicidal feelings and retirement depression, and there are links and things within that document for frontline professionals to seek further information, support and advice. And then finally, I just leave you with this final slide. This provides contact information for the 24/7 domestic abuse helpline and web chat. And this was an initiative by Suffolk County Council. It's supported by partner agencies, all working together to provide support, advice and action on domestic abuse. So that was a whistle-stop tour. I'm very conscious of time to give Catherine some time. So thank you very much for your time this morning. And that concludes my presentation.
Thank you very, very much, Melanie. If people wanted to use some of those resources, if they contact me or yourselves, we're happy to arrange to have them shared, aren't we? So you know, we obviously can't put them out on the fully the public domain till yeah, but obviously people can come and ask us. Just to mention, there is something in the chat in relation to highlighting that not all suicides may have be recorded as suicide at the coroner's court, and some actually maybe a drug and alcohol related death recorded, or even sometimes it's died by their own hand. So actually, so the numbers are impacted by that. But without any more to do, I'm going to hand over now to Catherine, who's from Restore, who's going to share about domestic abuse services. So Catherine.
Good morning, everyone. Hopefully you can hear me. So I've just been asked just to introduce some of the services that we have at Restore, and a little bit of pointers really of things I know about suicide. So I head up Restore Women's Aid, which is based in Bury St Edmunds, and I'm also a national police trainer, training police in DA matters, and I'll explain to you in a minute why that's important. So our service, obviously we've had a refuge for 50 years in Suffolk, but we also have 4 domestic abuse hubs across West Suffolk. They are based in Bury St Edmunds, Haverhill, Newmarket and Stowmarket, where we deliver a full range of services. We're very committed to getting into communities. We don't want people to have to travel to our services. We want to go out to them. So we offer, one of the first things we do, which is very relevant to suicide, is obviously we risk assess everybody. We do one-to-one appointments. So that means a dash. And on the dash, there is the question of, have you had any thoughts of suicide? How is your mental health? That sort of thing. So it's a priority to us. So we do one-to-one advice appointments, the risk assessments, as I said, safety planning, referrals to any services or agencies, because that's really, really important. Obviously, things like IDVAs, Mareks, Anglia Care Trust, but also mental health services, housing, that sort of thing. We do a lot of what we call coffee and chat sessions, which are actually peer support services, drop-ins, so that anybody can access them. We run a comprehensive programme of domestic abuse recovery programmes, things like the Voice, Freedom Programme, Power to Change, Escape the Trap, loads, because that's vitally important for breaking the cycle of domestic abuse. We offer our clients trauma-informed counselling. We have counsellors in each of our hubs. And we do lots of young people support, because obviously we all want prevention of domestic abuse, don't we? So we talk to a lot of young people about healthy relationships, but also help them if they're in abusive relationships as well. So that's our services. And then just a few things I wanted to highlight, and a lot of this has already been said by Melanie. and Tim, but there's two reports that I think that are very, very useful. One is called Suicide is Homicide by Project Resist, and that's about the justice and inquest systems around suicide and homicide. And the other one is Living Without Hope, and that's by the Women's Trust. And that particularly looks at mental health services for domestic abuse survivors, and they are asking for a minimum of £27.5 million to be invested into mental health services for female survivors of domestic abuse, because we know that if we can get earlier intervention, that is going to be a massive help to reduce those suicides. And again, as Melanie said, it's so important that domestic homicides are now changing to domestic abuse related death reviews. So we're looking not just at a homicide, we're looking at when people take their own lives as well. Suicide is a massive issue within the domestic abuse sector at the moment. It is being highlighted the most I've ever known it. And that's partly because for the first time ever, the rates of suicide in victims is outstripping the rates of homicide. So the national rates are that 2 women every week are killed by their partner or former partner, but 3 women every week are taking their own lives because of domestic abuse. Now, one thing that does really strike me is think about that increase in those death-related reviews. So the domestic homicide reviews, you were looking at 2 a week. Think how many more we're going to have to do now because of this link to suicide. It is vitally important. And in fact, Jane Monckton Smith, who is an expert in domestic abuse, has recently said that she believes the suicide rate in women victims of domestic abuse is actually not 3 a week, it's between 4 and 10 a week. So that, we think it's underestimated. Also, just to put in a caveat as well, we know that male suicide rates are very, very high. It is a public health issue, and it's a huge killer of young men. We know that. But what's quite interesting is that male suicides tend to use more violent methods. So we know there's more female suicides attempts than there are males. And also the other interesting thing is that males don't often leave a note to say why they're doing it, whereas females will often leave a reason why they've done it. So that's something to look at. I also agree with exactly what Tim said about how perpetrators of domestic abuse weaponize suicide. They'll often do it on a significant day, like it could be the survivor's birthday or one of the children's birthdays, and they will often orchestrate the suicide so that the survivor will find them. So it is like weaponizing it afterwards. And again, as we've heard already in the presentations, you cannot separate the link between suicide and homicide when it's a perpetrator. We call it end-of-line thinking. So that's why one of the questions on the dash is, has the perpetrator ever talked about suicide, taking their own lives? Because that end-of-line thinking means that they actually, if they're ready to take their own lives, which is the ultimate way to take control back, and it's often when they get wind of the fact that the survivor is going to leave the relationship, if they're going to take their own lives, they're often willing to take the life of the victim as well. End-of-line thinking. And it's often the thinking is, if I can't have you because you're leaving, then nobody else will have you either. So we know it's very, very dangerous, and it's very, very linked. And the reason why I mentioned that I'm a national police trainer, so the police training is called DA Matters, that has been in all the constabularies now across England. As I've been doing it over several years, there is a change, and police are now instructed as part of that training to investigate all suicides or suspicious deaths, to look for domestic abuse, to preserve the scene, because what we believe is that domestic abuse related suicides were being missed. So consider, you might have the perpetrator saying, well, yes, she's got a history of mental ill health. I'm not surprised she's taken her own life. This is you know, what we expected. And so they weren't being investigated. It was sort of explained, if you like, by the perpetrators. So it's really important that we're seeing a change, both with the domestic homicide reviews and with police investigations as well. So as I said, it is a massive issue within the domestic abuse sector. And we are looking at it differently, and it is really taking a priority, and we really need to improve mental health services. And again, as Tim said, we need to ask the questions when we're talking to survivors. You know, please don't be frightened of it. You ask without judgment. If they say they have a previous history of attempts, or if they say they're thinking about it, you do a safety plan. Do they need to speak to their doctor? Do they already have mental health workers involved with them that they're accessing? If it's an emergency, you know, do you actually need to call the police? If they are telling you, and they're not with you, but they're telling you on the phone that that's what they're going to do, then you have to get police intervention. And there's some really good support. You know, Samaritans is amazing. Papyrus for young people is amazing. The Zero Suicide Alliance is amazing. They do free training. There's some really good apps that you can get as well to help people. The more we can have those conversations with people, the more we can intervene and put help and support in place. So just to urge people to do as much training as you can on suicide prevention. And, you know, I always say to my team, like, your first appointment with somebody, when you assess them, you should ask, you know, have you got any physical health issues that I need to know about? For example, mobility, like, can you get into our building? But also, have you got any mental health issues that I need to know about? Make it normal, because we are seeing so much more complex trauma in our clients that we've got to normalize those conversations so that people are open and willing to talk to us about their mental health. When you come to a domestic abuse service, they are completely non-judgmental, and as we heard on the earlier presentation, we believe them. You know, that is, they are going to be believed when they come to us. So we need to give them a safe space where they can talk about their mental health, and then we can put interventions in place and have those open conversations with them. I think that's probably enough from me.
Thank you, Catherine. Just to pick up on, I guess, yeah, a big theme of what you're saying is really important that we make suicide prevention and domestic abuse everyone's business, because actually, whether you're working in a primary care receptionist as a GP, whether you're a teacher, or whatever setting that we work in our personal life, in our professional lives, but also then as we work in our also in our personal lives, I get them around. It's really important to everyone's business. So we just want to highlight some of the training options which Catherine mentioned. I'm just going to share my screen now on that one here. Okay, well, hopefully you can see this. So yeah, Catherine mentioned the ZSA training, and there's various training that focus on different groups. So you can, yeah, so zerosuicidealliance.com. 20 minutes online training. There is a 4-minute video if you want to share something within your team meeting to get a discussion around suicide prevention. Also, there's assist training, which is a 2-day workshop. And also, if you're interested in that, I understand that YMCA Trinity are providing that locally, as well as other providers as well. Just as we're running out of time now, but just to sort of go through things that are coming up. So the next webinar next month will be on young people and suicide. That's Wednesday 25th at 10 a.m. and a sign up link will go out with the presentations from this webinar. This webinar and the previous ones and future ones will be on the Healthy Suffolk website. So if you Google Healthy Suffolk Suicide Prevention, that will take you to that. So you can watch them and catch up if you want to use them for your own CPD or with the team. And also just to conclude, it's really important, both the topics of suicide prevention and suicide and also domestic abuse are really sensitive topics. So really it's important to look after yourself. So yeah, the rest of today it's important to take time for yourself, to reach out to friends, and if you need help, make sure you seek it. So thank you very much for attending today, and we look forward to you joining us at future webinars. Thank you very much.